Vayan haciendo sus preguntas en eh, en la WOBA, en el app que tenemos aquí para el curso. Y aquí hay una pregunta que hacen para el doctor Aldo Torre. ¿Qué tendría de interés la manipulación de la microbiota en el grupo de pacientes que expresa TLR4?
Gracias por la pregunta, totalmente involucrado. Hay que establecer el microbioma de las poblaciones para poder establecer terapias específicas. La microbiota del mexicano no puede ser igual a la microbiota del asiático, la del europeo, la del norteamericano, e inclusive la microbiota de México por sur, centro y norte es diferente. El que más ha estudiado esto es el doctor Bayá. Él ya tiene identificado la microbiota en un subgrupo en Virginia, donde hay un predominio franco de enterobacterias, y eso propone terapias específicas, específicamente con probióticos hacia las cepas que está identificando, y tiene estudios muy finos inclusive de cuáles de esos gérmenes identificados están en el cerebro, provocan neuroinflamación, confirmado a través de espectroresonancia. Por lo tanto, ¿qué rol tienen los toll-like con la sobrepoblación bacteriana? Totalmente involucrado. Hay que identificarlos, bloquearlos a la par del antibiótico o probiótico en cuestión dirigido hacia los gérmenes identificados, pero para ser finos hay que tener el análisis de microbiota por entidad y específicamente en pacientes cirróticos, porque tampoco los cirróticos tienen la misma microbiota que los sanos.
Hay una pregunta, adelante, por favor.
Dr. Dahl or any of the other doctors, I'd like to ask you a question about some natural therapies that have, there's an extensive amount of research behind them. One of them would be the herb turmeric, curcuma in Spanish, the active ingredient being curcumin. It's been used for 2,000 years in China and India, but specifically it's been used, at least in mice studies, with liver fibrosis. And they exposed mice to a chemical, they pre-treated them with turmeric, it reduced the damage done, and it reduced the fibrosis, the development of the fibrosis, and it also has the capability of inducing apoptosis in fibrosis to help break down the fibrosis. Dr. Dahl, do you or any of the other doctors have any knowledge of this, these studies?
So I think you make very good points. Probably for fatty liver disease, just like heart disease, because it is so common in the population, we will need something that is very safe, very cheap, very easy for people to take throughout their lifespan. And so the ideal remedies would actually be natural products or probably mixtures of things. So many things have been studied in animal models, and they almost always work, otherwise the paper wouldn't be published. So they work in mice. The issue is whether or not the same things would work in people, and I'm a big proponent that we should have the same rigorous criteria that we use when we approve any drug. So if these other compounds work, that would be great, and certainly there are animal data to support turmeric and many other natural products as being efficacious in mice. It's very difficult to get these things properly studied in people, and the reason for that has to do with money. They are not the property of any pharmaceutical company, and it is very, very expensive to do clinical trials. And so no one wants to pay the money, or no one has the money to pay to study such drugs. In the US, there actually were studies, though, of silymarin, which was very effective, milk thistle, in many animal models, and it did not prove to be effective in people. So I would say we must study these in people to see if they will be effective in people.
I'll just mention one other natural therapy. You may or may not have any knowledge of it. Proteolytic enzymes, especially the German product Wobenzyme, which has been used for over 60 years. I don't know if you or any of the doctors have any. It's been used for other types of fibrosis, a lot of, trials in humans. I don't know about liver fibrosis.
I just want to take part of the discussion of curcuma. There are more than 2,000 papers published in PubMed regarding the effects of curcuma, not only in NASH, but also in other many diseases. Even neurodegenerative diseases like Parkinson's disease and Alzheimer's disease. In many places, like in the United States, they don't reject, but they use the curcuma as a preventive and reducing side effects before radiotherapy and chemotherapy. But what is lacking there is what Professor Deal says, is money to support studies, controlled studies in humans to apply this knowledge. The curcuma affects also the TLR4 receptors and the inflammation in general speaking. So this is a fantastic drug. It's a fantastic number of activities. There is no explanation for that, and it's very cheap and it's very inexpensive. Probably this is a kind of an opportunity for people like us in Mexico and in developing countries to find out new resolutions for a very expensive new treatments which are appearing in the market. Just to recall your mind, there are now in the United States 9 products in which these 9 products are very effective, but the cost per year is not more than $900,000 per month per year. So there are new drugs, but the accessibility of these drugs are impossible to be covered for the standard population.
René, por favor.
Dos preguntas para la doctora Dill. This is a question for you, doctor. Not for you, Dr. Dill. I'm going to say in Spanish because it's better for the audience. Dos preguntas directas. ¿Cuál es el papel que usted utiliza, el fibroscan? ¿Cuál es el rol que le da? Si realmente lo utiliza como para no utilizar la biopsia hepática y si utiliza vitamina E en su práctica.
Okay, so the first question was about FibroScan. I'm still exploring FibroScan in fatty liver, and I think many people in the US are. There are trials ongoing, but the data would suggest that it might be effective in helping us to stratify patients who would or wouldn't need a liver biopsy. So if I do use it in my clinical practice, I use the XL probe because most of my patients are obese. And if I have a very low number, I'm content to defer biopsy in someone that I might otherwise biopsy. If I have a number that's higher, and I don't have a particular cutoff, but when it gets in the 12 to 15 range, I become nervous, and I don't know whether that will be validated by the biopsy or not. So far, we are trying to biopsy patients that we select on the basis of FibroScan to see whether there's good concordance between those things. I would say it's pretty good. It's not perfect, but I do use it in practice, and I think in the US in general, it's being adopted. As far as vitamin E, I do treat some patients with vitamin E, but I treat according to the results of the study. The Pivens trial only enrolled non-diabetic patients, and they generally enrolled patients who did not have significant fibrosis. So it seems to be an effective therapy for some patients who are non-diabetic with mild NASH or mild fibrosis, but I temper my enthusiasm for people who are at high risk for prostate cancer, so older men, particularly men that have a history of prostate cancer, and also people that have a strong history of possible coronary artery disease, since there are some evidence that vitamin E may accelerate that process. So I do use it, but not in everybody.
Arturo.
Gracias. Yo quisiera felicitar a todos los ponentes por sus extraordinarias presentaciones y quería preguntarle a la doctora Diel en relación a pentoxifilina en enfermedad atóxica o en fibrosis.
So pentoxifillin is a very interesting drug, and I think that the NASH Clinical Research Network will probably be doing some clinical trials with that to try to see if it will hold up to testing in larger populations. There already are some small studies that suggest pentoxifillin may be an effective therapy in NASH, but they're small studies with short follow-up. But I like it as an idea.
Yo quisiera volver muy rápido al tema de la elastografía, ¿no? Hay por lo menos 2.000 o 3.000 estudios hechos en Europa, a los cuales se agregan cada día varios estudios en Estados Unidos sobre el beneficio del uso de diagnóstico rápido de si hay o no hay cirrosis en el hígado, sin meternos mucho a las etapas intermedias en donde hay mucha sobreposición. Hay tres maneras de hacer elastografía. Una manera muy costosa y muy eficiente, que es la elastografía con resonancia magnética, que solamente en algunos lugares que pueden pagar el estudio los pacientes y los equipos tenerlos a la mano, y tomaría un tiempo tener el diagnóstico del resultado. El ARFI, que ya lo mostró el doctor Marín, si tienen un equipo de ARFI y tienen un muy buen ecosonografista y tienen el tiempo para esperar a que el resultado, esa sería una opción. Pero lo más común y lo más útil, creo, en mi opinión, es el equipo de EcoSense, que es la elastografía común y corriente, que ya trae una potencial aplicación para medir la grasa en el hígado. Está en estudios el que se valide esta opción, pero creo que la opción más validada y más recomendada es la elastografía con el fibroscan, que creo que se ha familiarizado por todos lados en el mundo.
Otra de las situaciones es que no en todos lados hay fibroscan en México. Entonces, ¿qué utilidad tendrían los marcadores serológicos y el ultrasonido?
So I think you're hitting right on the area that everyone is most interested in. We have a huge population of patients that we're going to have to stratify according to risk so that we can afford to take care of the ones that need to be taken care of and let the other ones go. And right now, I think biomarkers are a very hot topic. In my mind, there are not proven biomarkers yet that help us reliably distinguish NASH from NAFL or even more advanced fibrosis in fatty liver disease. I think having gone to many talks about NAFL and NASH and heard other experts speak, I think there are some data that suggests maybe combining things like FibroSure type test with some sort of a FibroScan gives you the best sensitivity and specificity. Adding the two tests, though, will increase the cost. And, but still, I think most patients and most doctors would find that preferable to having a liver biopsy. And I agree with you completely, although MR elastography is phenomenal and very beautiful, it's still not achievable for most patients and most doctors, and it will be very expensive. So I think we need tests we really need point of care tests. Most of the patients with these diseases are actually not seen by gastroenterologists. They're seen by family practice doctors and by general internists. And we would like to be able to provide them a test to figure out who they should refer to us.
Hay otra pregunta, es sobre la elevación de la proteína C reactiva en el pronóstico asociado en infección no manifiesta. ¿Cómo podrían explicar esa situación? La elevación de la proteína C reactiva.
¿La pregunta es más específica para hígado graso o es en general? Bueno, en principio es un marcador de inflamación no necesariamente asociado a infección, y en particular en este grupo de pacientes distinguió en pacientes con Child C no infectados, el valor de corte fue, aún así, discernió para mortalidad, para riesgo de mortalidad. Probablemente por algún estado inflamatorio, no necesariamente asociado a infección, ¿no? Eso no es indispensable, pues, en mi conocimiento que esté presente una infección. ¿Perdón? Perdón. La pregunta era cómo explicar la PCR elevada en ausencia de infección. Yo sé que es un marcador de inflamación independiente, pues, de necesariamente un estado infeccioso. Y en este caso, incluso distinguió un subgrupo de pacientes Child C con infección o sin infección, y en ambos estuvo presente el valor de corte para mostrar mayor riesgo de mortalidad.
Bueno, yo quisiera hacer una pregunta críptica del tema. El tema de la obesidad y el sobrepeso amenaza con estar consumiendo y consumir cada vez más el presupuesto de los países destinado a la salud. Hace 40 o 50 años, yo me acuerdo que todos estábamos flacos, ¿no? En parte porque siempre hemos tenido deficiencia de calorías y en parte por las costumbres, ¿no? De repente hay un cambio rápido en la accesibilidad de calorías y hay cambios rápidos en el mundo de globalizar las costumbres de la dieta, ¿no? Y a pesar de que seguimos corriendo algunos, la mayor parte de la gente deja de correr, su hábito de vida cambia rápidamente y no es un descubrimiento que tengamos que volver a cambiar el hábito de vida si queremos resolver el problema de la obesidad y el NASH y dejarnos de tomar pastillas que no sabemos ni para qué funcionan. ¿A qué se debe cuál es la explicación que se da en Estados Unidos del cambio rápido en 40 o 50 años o menos de la conformación corporal del ser humano en tan corto periodo de tiempo? Porque hemos modificado nuestra estructura en 40 años más que en todo el resto del tiempo que hemos vivido como seres humanos. ¿Qué piensa la doctora Madil?
I think you raise a very good point. To solve the diseases that afflict us now, we probably have to have social change. It just will not be up to doctors and maybe not even up to individual patients. I had to prepare a report a few days ago, and I reviewed some very troubling information from the World Health Organization. They conduct surveys every so many years for global estimates of mortality, and the last survey was completed in 2010. And what they concluded was that death from cirrhosis or hepatocellular carcinoma globally was a greater cause of premature death than death from HIV. And I would think most people are probably not aware of that. Interestingly, for Mexico, just like many other countries where they call you, you're developing, most people in your society have achieved an average annual income of $3,000 US. In those countries, the highest risk for cirrhosis, but also complications of the metabolic syndrome, are actually poor people in developing countries. And there may be explanations for that. We know, and this may doom our societies to decades, if not generations, of bad things, even if we change our habits now. And that is the realization that our predisposition to obesity might be governed before we're born. It turns out in societies like Mexico, as you point out, where starvation was a problem a generation ago, the babies that were born to starved mothers are actually at high risk for developing obesity and complications of obesity once food becomes available. So they're at higher risk than babies that were born of healthy mothers. Similarly, babies born of obese mothers are at higher risk for developing obesity and diabetes. So you can see if you were a poor country, you had a population of people who were predisposed to obesity, and then availability to food came in, and they were more likely to become obese or diabetic. And now they're going to have children who are going to be more likely to be obese and diabetic, even if we change our behavior now. And so the World Health Organization has targeted obesity and liver disease, actually, as significant global health problems. And they, like you, point out that this is a problem that requires social change.
La última pregunta, ya se nos acabó el tiempo. Adelante, Sergio.
Sí, una pregunta para la mesa y en particular para la doctora. ¿Cuál es su opinión o cuál es el papel actual de la biopsia hepática? Dado que en nuestro país la disponibilidad del fibroscan y las pruebas serológicas son tan bajas, ¿hay alguna población que tenga más riesgo, por ejemplo, diabéticos o que ingieren alcohol? ¿Cuándo indicaría la biopsia hepática?
So I still do a lot of liver biopsies. I think there is a role for liver biopsy in patients who you think have a risk of developing significant fibrosis. So that would be the high-risk populations that I talked about, people that are overweight or obese and over the age of 45 or 50, people that are diabetic and over the age of 45 or 50, people that have evidence of portal hypertension or subtle stigmata of cirrhosis on your exam or on lab testing. So people that are at high risk for fibrosis, I biopsy to confirm my clinical suspicion. If I already know they have advanced fibrosis, I don't need to biopsy them. And if I don't think they're going to get advanced fibrosis, I don't biopsy them.
Pues muchas gracias, agradecemos estar con nosotros y muchas gracias a todos los ponentes que estuvieron excelentes.